Hello.
Welcome to the 45th RSSDI.
Thank you very much. Yeah, I am Dr. Abhichandani from Ahmedabad. I am a practicing diabetes and endocrine physician. So please let me answer some of your queries here.
Today this morning we had a session on the extra glycemic benefits of GLP-1 analogues. So what is your take on that, your insights on it?
Yeah, first of all, let me honestly admit I missed that session. But having said that, based on my individual experience, I can relate to your question. And first of all, I would like to highlight the weight reduction property of GLP-1 analogues, especially liraglutide, which I have been using extensively in my practice. And we are awaiting the launch of 3 milligram of liraglutide, which goes by the brand name Saxenda. And that should augur very well for all obese, even non-diabetic obese patients. Besides weight reduction, there is a small but significant reduction of systolic blood pressure seen in this class of agents, and we also observe some correction of lipids, which all this culminate into reduction in overall cardiovascular mortality that was expressed with the outcome shared with us from based on the leader trial involving liraglutide. And recently a host of trials, complete data from the Trulicity molecule. So they have again come out with very reassuring data, and the product has been now approved for as a CV safety and a product with lot of beneficial pleiotropic benefits in the diabetes subgroup.
Cardiovascular and renal events, and if so, is there any benefit and in which kind of patients?
Again, the two classes of agents would be preferred in overweight or obese diabetics who are, if I think only of SGLT2 inhibitors, it is a unique mode of action, insulin independent, but somehow its usage is associated with elevations of glucagon levels, and which is very nicely looked after institution of an incretin based therapy, including a GLP-1 analog. So if my patient accepts a combination of GLP-1 analog and SGLT2, which turns out to be a pretty expensive one, but for those of my affording patients who are handpicked for the two products, I think it has a wonderful outcome with much more pronounced weight loss, a more robust correction of systolic blood pressure, and associated lipid benefits.
So lastly, how do you address the patient-related barriers in initiating an insulin therapy?
I think I can more confidently answer this one. The reason is I am a very aggressive prescriber of insulins, and I find this psychological as well as sometimes genuine barrier coming up all the time, and the best way I address this barrier is to reassure my patient that this is the ultimate gold standard way of treating treating diabetes with the help of insulin, even if it is a newly detected diabetic, or even if it is the patient is in the 5th year, 10th year or the 20th year of his diabetes history. The gold standard according to me remains insulin, and that to a good quality analog basal insulin. And I tell my patients the new generation of tax savvy pens and 32 gauge needles, which are perhaps less painful than the bite of an ant, and I sometimes give them a demo on myself just to make them really be confident of using the insulin injections. And if they have heard of some false stories or hyped up stories of hypoglycemia and weight gain, I reassure them the newer generation of analog insulins are much devoid of such side effects. They have the flexibility of being injected per meal or even post meal. So I go out of my way to make sure my patient accepts my recommendation, and I most of the time succeed in doing so.